for asking me to share with you some of the concepts about management of coloboma with retinal detachment. We all know about what a coloboma is, so I won't go into the details about the embryogenesis and the reason why a coloboma forms. We know that it is because of the defective closure of the embryonal fissure between 4 to 6 weeks of gestation. And the severity of coloboma can vary depending upon at what stage in the development of the eye that the insult has taken place. Most often it's the intrauterine insult due to malnutrition, viral infections, X-ray, etc., etc. So these, at what stage the insult has occurred will dictate how severe the coloboma is. And it's just to show the various varieties of coloboma where the optic disc could be involved within the coloboma or it could be outside the coloboma and be independently also affected by a coloboma. Okay, and this is where the disc is within the coloboma and has both components. All right. The importance of this is that the optic disc is involved, macula very often is at the edge or within the coloboma, and hence it dictates the amount of vision that the patient presents to you with, as well as the final vision when you correct the retinal detachments. Also of note is the presence of often bilateral problems, not compulsory, but it can be more often than usual. Microphthalmic eyes, which has a special importance when you do surgery on them because you need to make the sclerotomies a little anterior rather than the normal eye, normal size eyeball. Nystagmus, which makes it difficult sometimes to evaluate the eyes pre-operatively, and very often during surgery that you notice exactly all the features. And I also alluded to the disc and macular involvement. Of relevance is this excellent article from Dr. Schubert, which has really opened my eyes as to the concept of why the subretinal space and sub-ICM space communicate and where. This is a study of histopathology of colobomatous eyes by Dr. Schubert, which show that the retina, when it is traced from the normal background towards the colobomatous margin, actually splits into two layers. This is the outer layer and this is the inner layer of the retina. The outer layer splits into two, and the retina splits into two, and the outer layer turns back. Outer layer is nothing but photoreceptor layer. It turns back and merges with the retinal pigment epithelium, and this is the junction which he named as locus minoris resistentiae. This is very vital for the understanding of the pathogenesis of detachment of retina. And you see that the inner layers, which is the ganglion cell layers, bipolar cells, etc., they continue on beyond the coloboma margin, but they become sort of a fibrotic membrane which is called as intercalary membrane. And the extent to which identifiable retinal layers exist in the ICM can vary from eye to eye. There are many eyes where right at the margin it transforms into fibrosis, and many others where you can see identifiable retinal cells even as far as the middle of the coloboma. So as I said, this point is very important for understanding. So when you find retinal detachment with a colobomatous eye, you have basically three variables in the retinal, I wouldn't say retinal break, a break in the retina or ICM. So a peripheral retinal break could be present. There could be a break at this locus minoris, which is, as I told you, communication between subretinal space and sub-ICM. It's a barrier actually, which is present provided it is a continuous between subretinal space and sub-ICM space. And then there's a break in the intercalary membrane itself, communicating into the vitreous cavity, the sub-ICM space. So if we find a peripheral break alone present in a given eye of coloboma, and if you're 100% sure, we're talking about concepts, not because you can definitely exclude a break at the locus minoris resistentiae and clinical examination, but let us worry about the concepts first. If it is a peripheral break alone, then the retinal detachment involves the normal retina and it stops short of the coloboma because there is a barrier created by the locus minoris resistentiae, and there is no detachment of the intercalary membrane unless it is separately affected by a different ICM break. A routine management is all that you need in these cases. That is just like in any eye without a coloboma, because the causation is not related to the coloboma itself. But you can have a peripheral break along with a break in the locus minoris resistentiae. As I told you again, this barrier, when it's broken, there is a communication between the subretinal space and the sub-ICM space. The problem is that this cannot be identified clinically. You assume it is there based upon what you see in the detachment pattern, as well as you can use a tool called OCT. Here the retinal detachment is of the normal retina. There is a variable extent of ICM detachment depending upon where the communication lies. The entire ICM need not be lifted. There may be a small pocket of ICM detachment that tells you that is where the communication exists. As I said, clinically you can't identify the break in the ICM because we are talking here of only concept of only two breaks, not a third break as yet. It's impossible to locate the brake near the border of coloboma clinically, and only a peripheral buckle may succeed if you can definitely rule out an ICM brake, because the brake at the junction of the coloboma with the retina, that is the locus manoris resistentiae, is not in communication with the vitreous cavity. It's a peripheral brake which is in communication with the vitreous cavity. If you seal it, everything should be okay, provided you are sure in your estimate and judgment of what is happening. Otherwise, you do vitreoretinal surgery. Now, this is just a slide which shows that OCT can be a useful tool to identify the communication. You can see that this scan done at this point shows no communication, shows a communication between the sub-ICM space and the subretinal space, while a scan just beyond at this point does not show the communication. You can see that this unit, this entry is sealed off by this barrier, right? So OCT could be a tool, provided you are able to do it. Against small children, you may have difficulty. There are also situations where there may be only a break in the intracalary membrane. If you have a break only in the intracalary membrane, like you have in this case, you can't see it in the photograph, but you see the ICM detachment. This is ICM detachment. This part of the ICM is not detached. And you find that it stops short at the colobomatous margin because the sub-ICM space is not communicating with the subretinal space. There is no fluid beyond the coloboma margin. Again, this is not always easy to exclude because of the nature of nystagmus, macrophthalmos, etc. And tiny areas of fluid along the coloboma margin can be missed clinically. And the role of prophylactic laser around the coloboma we'll discuss a little later. What about breaks in the intracalary membrane and the locus manoris resistentiae, but no break in the peripheral retina? This is perhaps the commonest way that retinal detachment occurs in a colobomatous eye, where you do not find a peripheral retinal break because the vitreous is still attached, at least in most of the situations. And you find here, for example, the ICM detachment is here beyond the coloboma, and this is a clinical retinal detachment. They are continuous. And there will be a break somewhere in the ICM. In this case, you can see it here. And the ICM is detached to a variable degree. No peripheral break is in. This is the commonest combination you see. So when you find the break is at all the three places, it's similar to the last component I discussed. So how do we manage them? Mostly we manage by vitreoretinal surgery. But yes, you can do buccal if it is an eye with the first category where there's only peripheral break and you're 100% sure there's no other break. When you do VR surgery, which is what we end up doing in most cases because you're not 100% sure, this is the procedure. The location of sclerotomy is, keep in mind the macrophthalmos. The role of the encircling band is questionable. If you do a good vitrectomy, sacrifice the lens, then perhaps encircling band is not a must, because you see that the inferior coloboma, if it is large enough, which is very common in the situation, you find that the most of the functional retina is above the 4 and 8 o'clock meridians. And so encircling band probably is not required if you can give a good tamponading agent. Save the lens or lensectomy. Very often you end up sacrificing the lens because of the microphthalmic eye and inability to dilate the pupil properly, etc. Again, the pupil tends to be eccentric because it's drawn towards the colobomatous area. The superior pupil tends to be rigid and doesn't dilate as well, and so you may end up putting iris hooks superiorly so you can do a good vitrectomy. Now in the in the vitrectomy you do a peripheral debulking of the vitreous base, and PVD, as I said, is very often absent, and while inducing PVD it can be a traumatic procedure, and that fine barrier I talked to you about can be broken because of your violent exertions to detach the vitreous, and that has to be kept in mind when you do the when you do the laser around the coloboma. Although the original communication is only say 1 quadrant or 1 clock hour, because of your violent maneuvers of detaching the vitreous, it can extend beyond as well. And when you detach the vitreous, you tend to start in the healthy retina and try to peel towards the coloboma than the other way around. Okay, although it's easier said than done, you need to really maneuver your way out so that you do least trauma to this border while detaching the vitreous. Sorry. Okay, the identification ICM break is not. The identification of ICM break, if not already done, can be done at this stage. You can see the ICM breaks. Because the lack of contrast, they are not visible clinically easily, but you can make it out intraoperatively. But it's not vital that you identify the ICM breaks because you're not going to treat them anyway. That just makes you feel happy that you identified the ICM breaks. But more important would be to identify a narrow band of ICM detachment that can be easily missed preoperatively, because that tells you that the coloboma is indeed contributing to the detachment, and you need to treat the borders of coloboma. So what if you do fluid gas exchange at this stage, and how does the retina behave? If there is only peripheral break and no broken barrier of locus minoris and no ICM break, then, and if you just suck out the fluid from the optic disc, the whole retina gets pushed towards the colobomatous border. But the retina balloons around the coloboma because it has no path to exit into the vitreous cavity, and it doesn't spill over to the colobomatous area. That tells you that coloboma is not responsible for the detachment. Again, you can do a peripheral retinotomy, flatten the retina, and may not even treat the coloboma border if you don't want to. But once we are inside, we always try to treat it. If there is a peripheral break and a break at the locus minoris restitiae, the behavior is exactly same. Retina balloons, does not flatten, but the ballooning spills over into the colobomatous area. On the contrary, if you have a break in the ICM as well, then the water, the subretinal fluid gets communication into the vitreous cavity, so it gets flattened even if you don't actually go into subretinal space and suck out the water, the subretinal fluid. So that tells you that there is a direct communication between subretinal space and the vitreous cavity. The role of relaxing cuts, if ICM detachment is taut near the breaks, it can keep the ICM lifted up with air, and potentially this can lead to recurrent detachments near the border. It can be relaxed by radial cuts or total excision of the tissue, but beware that you may be actually cutting across major vessels which may be crossing the coloboma to supply the normal retina. So you cannot cut those vessels, it will compromise the visual function. It's very rarely that you need to really do relaxing cuts. Photocoagulation is along the peripheral retinal breaks. I think I'm spilling over my time limit, so I'll quickly go over them. So you go use preferably a diode laser rather than a green laser, because it doesn't cause damage to the nerve fibers, especially when you are going around the optic disc and macular area. Choice of internal tamponade is silicone oil, because you would like to tamponade the entire border of the coloboma. And there is no need for inferior iridectomy in most cases where there is iris coloboma present. Gas can be used in selected cases where you are sure the communication is only related to one sector of the coloboma. And silicone oil removal can be safely done even after 4 to 8 weeks after surgery, because you are not dealing with a PVR case, etc., where once the retina is fixed, it's pretty safe to remove the oil. There are cases where there is a flat antechamber and glaucoma. We removed even about 10 days after surgery, and they are doing pretty well. But when you remove it, please carefully evaluate the intercalary membrane for any pocket of fluid and whether it is spilling over beyond the margins. If need be, do additional treatment. There is a 10 to 30% recurrence after oil removal, more because you are not careful in detaching the vitreous first time, in not evaluating the colobomatous margin. The causes of recurrent detachment are incomplete vitrectomy, inability to produce adequate retinoplexy around the coloboma, PVR, which is relatively not uncommon, which is not very common. And prophylaxis in eyes with coloboma theoretically can reduce the risk of detachment, but beware that if you burn the full thickness retina around the coloboma of the disc, you can actually produce no PL because of your aggressive treatment. So if you are treating around the border, please, very light burns, preferably with a diode laser using a slit lamp delivery is what I would recommend. If it's extra coloboma not involved in the disc and macula, it's pretty safe to do a prophylactic laser. Thank you.